Welcome to week 4. We're talking about the CMS payment programs. Payment of health care. Patient pays for care themselves is called a self-pay. Private insurance pays for care. That's where employer provides insurance or health care benefits, or either the patient purchases health insurance. If the government pays for care, it's under Medicare, Medicaid, SCHIP, our Veterans Administration, or other grants and programs. The big gorilla in healthcare. In 2012, Medicare, Medicaid, and CHIP spent $1 trillion, 36% of the USA's total healthcare expenditures. Participation imposes many requirements and potential liability. Here you see where Health and Human Services is at the top of the organization chart. CMS, which is Centers for Medicare and Medicaid Services, fall right below that, and then Medicare and Medicaid fall below CMS, which is Medicare federal, and Medicaid is federal and state. Medicare was enacted in 1965 due to a large number of uninsured. Medicare is generally available to persons who are 65 and older if they or their spouses pay Social Security taxes for 10 years, or persons with certain disabilities, or persons with end-stage renal disease, which is ESRD. There are different parts of Medicare. You have your Part A, which is hospital, your Part B, supplemental, your Part C is Medicare Advantage, and your Part D is prescription benefit. As for the Part A and Part B, that's the traditional Medicare or fee-for-service. Beneficiaries don't pay a premium for Part A insurance. For provided through private plans that contract with CMS is Part C and Part D. But understand that Part B, C, and D, beneficiaries do pay a premium to obtain that coverage. Medicare Part A covers inpatient hospital services up to 90 days, skilled nursing facility up to 100 days following inpatient hospital stay, home health care following hospital stay, and hospice and inpatient psychiatric care for up to 190 days. Medicare Part A provided automatically to eligible beneficiaries, no premium is required, and persons who do not qualify may purchase Part A for a premium if they also purchase Part B, and beneficiary must pay to providers any applicable cost-sharing amounts, such as deductibles, co-insurance, or co-pays if applicable. Medicare pays to providers the balance for Medicare-approved costs. Medicare Part A is funded by payroll taxes, interest from trust funds, taxes on Social Security benefits, and other miscellaneous services. So no premiums from the beneficiary. Administered through the Hospital Insurance Trust Fund. Payments to providers under Part A is reasonable cost basis. That's where providers paid according to the service provided, usually according to the Medicare fee schedule, and then certain hospitals are still paid on a cost basis. You have your prospective payment systems, which are mostly hospitals are paid at a flat amount based on diagnostic related groups, and if cost of care is greater than the DRG payment, hospitals suffer the loss. Medicare Part B covers anything that's medically necessary. That could be physician services, services by Medicare approved practitioners who are not physicians, durable medical equipment and supplies, outpatient hospital services, outpatient mental health services, clinical laboratory tests, diagnostic tests, outpatient occupational, physical, and speech therapy, home health care not covered by Part A, and many preventive services such as your mammograms, prostate cancer screenings, colorectal cancer screenings, flu shots, etc., and as well as your ambulance services. Your Medicare Part B is persons eligible for Part A may enroll in Part B on a voluntary basis by payment of a monthly premium. They must pay Part B premium which could be anywhere from $100 to $350 per month, depending on their income level. And then the cost sharing amounts is applicable to the specific covered item, where they have a deductible or co-insurance or copay. And Medicare pays its share of Medicare approved costs, which is 80% of the Medicare approval rate. Medicare Part B is funded by the beneficiary premiums. They are adjusted according to the needs and federal general revenues, and it is administered through the Supplementary Medical Insurance Trust Fund. Medicare Part B, physicians paid the lower of the submitted charge or Medicare fee schedule based on the relative value score, which is RVS, associated with specific service. And then your physician fee schedule is supposed to be reduced each year by a sustainable growth rate system. And every year, legislature overrides the SGR reduction, and services are assigned a current procedural terminology code in process of moving to the new set of codes, CP10. Now, Medicare Part B, physicians can choose whether to participate in Medicare. We have participating physicians and non-participating physicians, and any that opt out entirely. With the participating, they do accept Medicare approved rates. They bill and is paid directly by Medicare and cannot bill the patient, balance bill the patient. Non-participating physicians don't have an agreement, but they determine whether to take the assignment on a case-by-case basis. If they accept the assignment, they're limited to 95% of the Medicare approval rate. If they do not accept the assignment, they're limited to 115% of the Medicare approval rate. Now, example is a service for which Medicare fee schedule is $100. So here you have a participating physician. Their total payment rate is 100% Medicare fee schedule, which is $100. The payment amount for Medicare is 80% of that, which is $20. So that $80 has to be written off. They can't bill or balance bill the patient. Now, for your non-participating physician, they are paid at 95% of the Medicare fee schedule, which is $95. And then the payment amount for Medicare would be 80% of that, which is $76. And then the balance left over is $19. And that's what's paid by the patient, or if the patient has a supplemental insurance. Now, a non-participating unassigned provider has a limited charge, which is at 115% of the actual billed amount, which is $109.25, which is $109.25. I'm sorry, it's billed at the limited charge of 109.25%. And then we pay Medicare pays 80% of that, and they can bill the patient what's left over, which is $19, and then they can balance bill the patient. Let me go back. $76 is paid at 80%, and then the 20% is paid by the patient, or supplemental insurance, and then they can balance bill the patient whatever the supplemental doesn't pay. Now, Medicare Part B, certain other providers are required to accept assignments, such as your physician assistant, nurse practitioner, certified registered nurse, certified nurse specialist, nurse midwife, clinical social worker, clinical psychologist, and they do not require provider agreements. Medicare Part C is known as the Medicare Plus Choice Plan, and as alternatives to Medicare Part A and B, eligible beneficiaries can choose to enroll in the Part C private health plans. This is where they have premiums or cost sharing, and it may be cheaper. And also the Medicare Advantage plans may impose additional restrictions requiring them to see certain providers. They do have coverage. All plans must cover at a minimum of Part A and Part B services. Their plans may cover additional items such as vision and hearing, and they may offer reduced cost sharing or premiums for certain items. Now, the Medicare Part C, eligible beneficiaries pay premiums to enroll in the plan. They usually have deductibles and co-insurance or co-pays. And Medicare pays plans a capitated amount based on the number of Medicare eligible beneficiaries enrolled in their plans. Medicare Part C is funded by enrollee premiums, and Medicare pays Medicare Advantage plans to provide the benefits, and it is administered through HI and SI trust funds. The Medicare Part D, which is the prescription program, eligible beneficiaries may join if they're approved by Medicare or if their Part C Medicare Advantage plan offers a prescription drug benefit. Their coverage is approved plan must offer at least a standard drug benefit approved by Medicare, and of course it may provide additional benefits. Now, the Medicare Part B eligible beneficiaries do pay a premium to enroll in the plan. It depends on the plan, but averages about $32 a month. Cost sharing amounts is a deductible or co-insurance or co-pay. And then they may have a donut hole in minimum Part B plans, whereas part of the plan is paid by the plan. And, this is an example at the bottom. Say, for instance, the plan pays $3,000, and then say the plan pays $4,700. You take the difference, and the beneficiary pays what's left over. Now, Medicare Part D is funded by the beneficiary premiums. It has general revenues, state payments for eligible beneficiaries who would otherwise qualify for Medicaid, and it's administered through a separate account in the SMI trust funds, and Medicare pays plans a certain amount per enrolled beneficiary. For Medicare Supplement, which is the Medigap insurance, this is where it covers what Medicare doesn't pay. It's a long-term care. It could cover dental, health care outside the United States, chiropractic, hearing aids, and eyeglasses, and any unnecessary services. They can purchase private Medigap insurance to cover the gaps in the Medicare coverage, and they will have a deductible or co-insurance, but Medigap insurance cannot pay Medicare Advantage deductibles and co-pays. Now, as far as claims processing, the Medicare Parts A, B, and B, and the Centers for Medicare Services contracts with private companies, for Medicare Part C and D, Medicare Advantage plans and Part D plans handle their own claims processing. So for Medicare, providers who receive Medicare money, they must comply with numerous statutory, regulatory, and contractual provisions. If they fail to comply, they could result in denial of payment, repayment of amounts improperly paid. They could also have civil and criminal fines and penalties, or be excluded from the Medicare program, which can adversely affect the ability to get a job in healthcare. So, what's the future of Medicare? The trust fund is expected to become insolvent within 10 years. The cost of Medicare Parts B and D continue to increase, resulting in increased premiums to beneficiaries. And Congress repeatedly delays the cuts in physician fee schedules required by the SGR system. The Affordable Care Act requires lower payment rates for other providers, but that likely will not be viable. Also, the federal government is trying to change structures to preserve long-term viability, such as pay for performance, Medicare shared savings programs, and demonstration projects. So as you can see here, there is a picture of the United States, and Medicaid does cover a lot of states in the United States. This is the end of week 4.